My name is Stan Hudson, and I'm Associate Director here at the Center for Health Policy. And it's my pleasure to announce our next guest, Mr. Ignatius Bao. He's a renowned health policy consultant and has been a strong national advocate for the health equity movement that Dr. Troutman so eloquently described this morning. He has directed policies and programs for the California Endowment and Asian and Pacific Islander American Health Forum, during which the forum led community efforts that resulted in the formation of the first White House initiative on Asian Americans and Pacific Islanders. He has consulted for a diverse and esteemed list of organizations from California to Connecticut. As a health policy expert, he has served on over 40 national board of directors, committee, and task force, ranging from the National Institute of Health, the National Quality Forum, the CDC, the ONC, and various state and metropolitan agencies. Today, Mr. Bao will be discussing how to achieve patient-centeredness and equity in healthcare. Please join me in welcoming Mr. Ignatius Bao.
Thank you, Scott. So this is always the most challenging part of any conference, the after-lunch talk or session. But I'm going to try to engage you in the conversation over the next hour and really try to make it a conversation and dialogue and keep as much time as I can, even though I have a lot of information to share with you for questions and answers at the end. I want to start, though, in the same way that Dr. Troutman started, which is my own life story. And my life story starts as an immigrant from China. My parents were both from Shanghai and came to the United States via England, Hong Kong, Japan, and a couple of stops in between, like many immigrants. As immigrant parents, they worked hard. They made sure that the 3 kids that grew up in this country had the opportunity to do better than them in a lot of ways. My mother eventually did get a master's degree and in her own way was a champion for social justice and social change because she was one of the first bilingual teachers in Chinese in the San Francisco School District. And it was part of a landmark Supreme Court case that created those positions that we often still rely on in terms of providing language access in healthcare. My father was an accountant and very, very quiet when we grew up. And when my mom was diagnosed with breast cancer when I was a teenager, I experienced healthcare in a way that probably no teen ever should. And when she eventually died from that, I had my first sense of what healthcare could be and what healthcare ought to be. When my mom died at age 14, 6 months later, my dad asked me what I wanted for my 15th birthday. And this was my first foray into being a public health advocate. I said, I want you to quit smoking because I don't want you to die. And in, I think, the beginning of a new relationship with my father, he quit smoking immediately. He didn't go to class, he didn't go to his doctor, he just quit because his son asked him to. And that began a wonderful relationship, or continued a wonderful, different kind of relationship with my father. I went to law school. I was privileged to be part of another social change movement around immigrant rights in the 1980s. People of faith reached out and protected Central American refugees who were coming to this country, in large part because of United States intervention in Central America. And so I was, as a lawyer, privileged to represent a lot of Central Americans, Mexicans, Southeast Asian immigrants and refugees. I represented HIV-positive Haitians who were imprisoned at Guantanamo Bay and eventually gained their release, even though the Supreme Court ultimately ruled that Guantanamo Bay was off limits and that the US could essentially do anything it wanted without US jurisdiction over that. And we now know that Guantanamo Bay, after 9/11, had other uses because of that legal protection, unfortunately created in part by that Supreme Court precedent. I also, as someone who then finally came out as a gay man in the late 1980s, also took on the issue of HIV and AIDS as a public health issue, but also a community issue. And I think I'm very grateful, like many gay men of my generation who survived the HIV epidemic, learned about leadership through that as a community, we needed to provide leadership for ourselves rather than looking to others. And I think that still remains a lesson in patient empowerment and in community leadership. And then, as Scott mentioned, I was really privileged to eventually get President Clinton to sign this executive order, which created a White House initiative that focused on Asian Americans and Pacific Islanders across the federal government. And just yesterday, President Obama named 14 additional new members to this Presidential Advisory Commission that has actually continued throughout the Bush and Obama administrations. And through that time, I've done a lot of public speaking from out in the streets against Proposition 187 in California to national conferences. And when I was at the California Endowment, which was a private healthcare foundation in California, I was really privileged to then continue to work on these issues of language access, cultural competency, health workforce diversity, and healthcare disparities. And I think really try to build what Dr. Troutman talked about in California, which is systems of care that were devoted to the issues of equity. And then finally, it is always personal, the work that we do. And so this is now my father, and I was privileged to help take care of him until he died 18 months ago at the age of 92. And that's his stepmom, who he remarried, and I was privileged to also take care of her until she passed away a couple months ago as well. And so in those last 18 months, I've had a tremendous amount of experience and exposure to the healthcare system of what works well and what doesn't work well, especially in end-of-life care. And I think there's many, many lessons that we need to learn about how to do end-of-life care better. And then finally, it's personal about myself as well. This is my partner of nearly 24 years. We are still single. We are not married. And that always gives me pause every time I fill out a form. Are you single or married? I have to check single. But he has been a partner not just in love, in life, but a partner in work as our work lives have converged. And he is now an activist for the right to marry around the country, as well as many other issues that he is involved in. So that's about me, and that's my journey to come before you today. And so what I'm going to give you then is, informed by that journey, informed by that experience, my view of the US healthcare system. And in healthcare policy, we often talk about this triangle of access, quality, and cost. And if you think about this, sure, we can increase access for everybody, and then we might not have as great quality, or we might run up more costs. Or we could just cut costs, and oftentimes, especially in public programs, there's actually this very perverse way in which we cut costs by limiting access. We purposely drop people from the Medicaid program in a way to save money. And actually, Medicaid programs know this. A lot of people don't know this. They say, well, let's add these additional requirements. Let's have them come and verify their income. And we know statistically and by experience, if we add that requirement, people will drop out of the program. Not because they're not eligible, but just because they can't meet that particular documentation requirement. So it's a very cynical and perverse way to do that. So the challenge in terms of US healthcare system is, how are we doing? In access, we're not doing very well. So this is 2010, before the implementation of the Affordable Care Act, 16% of the United States was uninsured. What I also want you to look at on this that is important is that Medicaid was already more important as a payer than Medicare. All right? So with the expansion of Medicaid in those states, it's going to be even more important. We hope Missouri also expands Medicaid at some point. But already Medicaid was a really, really critical public factor in the way that healthcare was paid. That 16% is just a figure or a percentage. It's 50 million people in the United States. And I think that's the more important number to think about, that there's 50 million people in the United States that began 2010 without health insurance coverage. And therefore, we can't have a system that's functioning well if those people are essentially outside of the system. And then, of course, in terms of equity and disparities, what I want you to focus on is the circled that while whites are at 15%, blacks are at 20% uninsured, and most importantly, Hispanics are at 30%. And so health insurance and increasing health insurance is a matter of equity. It's not just a matter of addressing one of the problems in our healthcare system, but it's also a way to equity. For LGBT folks, this is one of the few studies that was done on this over the summer of last year before the Affordable Care Act was implemented. Not a great sample, but showed that up to 34% of LGBT folks that were in this survey were potentially uninsured. Here in Missouri, you know what the figure is, that overall you're probably better than the national average. But what I would point you to is for African Americans in Missouri, the uninsurance rate is nearly 18%. All right? So we're not doing great on access. How are we doing on quality? The Institute of Medicine issued this report in 2002, and it said 1/3, 1 out of every 3 patients gets harmed in the hospital. Okay? So it's not only that they don't get better, the hospital actually does something to them during the stay that makes them worse. All right? This is national. So it's not pointing fingers at any particular hospital. It's just saying that our standard of care is such that 1 out of 3 people actually get harmed, affirmatively get harmed. That's not healthcare quality. 1 out of 5 who leave the hospital come right back to the hospital. All right? So think about that. You go to a restaurant, 1 out of 3 times you get sick. That restaurant's not going to last very long, right? Any other kind of service, okay? We can talk about car mechanics. We can talk about other kinds of service industries. Those kinds of that kind of service level wouldn't stand. And yet that's been what it has been in the United States. So not to just pick on hospitals. This is outpatient care. And this is a little bit difficult to read. This is a study conducted by RAND that said in those areas where there's clear clinical guidance, okay, so it's not this ambiguity of what do we do with this patient? This is an interesting diagnosis. It's the patient has asthma. Is the asthma under control? The patient is diagnosed with breast cancer. What are the steps to addressing and treating that cancer? All right, so when there's clear clinical guidance, then are physicians following that guidance? And for the highest, it actually is breast cancer. And I say that's, again, similar to HIV. It's because women have organized around breast cancer and have all kinds of information from all kinds of organizations that they go in empowered with the knowledge to say, that's the treatment you should be giving me, and having lots of dialogue and questions with their provider around that. All right? We don't do that for a lot of other conditions. And I always point to the last one, which is alcohol dependence. The physician knows that the person has an alcohol problem, but only 1 out of 10 times is the physician actually intervening effectively with that alcohol dependence. All right? So that's not a great record for outpatient either. And so that study was done in something like 2007. Every year, the US government dutifully reports, this is how we're doing on healthcare quality. And every year it says exactly the same thing. We're making a little bit of improvement, but we have a long way to go. So when those numbers that were for breast cancer in 2007 were 70%, they're closer to 80 to 90%. The numbers that were in the 40% are now in the 50s and maybe the 60s. All right, so we have improved. We have done better over time, but we still have a long way to go. It has a companion report that's issued every year about healthcare disparities, and what that says is exactly the same thing, that those disparities continue to persist, particularly for racial and ethnic minorities, and now the disparities report is beginning to talk about rural disparities, talking about disparities for LGBT folks, talking about gender disparities, talking about disparities based on primary language, talking about disparities based on income and education. So really taking a much broader view of what disparities is. But again, the story is the same, which is we're not doing good for everybody, but we're doing even worse when we look and stratify the data and look at it closely. So we know this about LGBT folks. We know this here in Missouri. This is from your hospital association that said a different way to look at the data, which is how do you compare with other states across the country. And Missouri isn't doing great on a lot of these measures. But again, the country isn't doing great on a lot of measures. So it's not necessarily something to focus on. It's something to say that we all systematically have to do better. You also have much better documentation of this. You all were given these reports. I commend them to you if you haven't seen them, from the Missouri Foundation for Health, which is great to actually give you that up-to-date documentation, and that's so important. So we're not doing great on access. We're not doing great on quality. Are you getting depressed yet? How are we doing on cost? All right, we're a great market leader in the world in terms of our free capital system. Okay, here's how we're doing on costs. Going up and up and up. And it says, what this chart says is that we're spending all this money, and we keep spending more money for not great access and not great quality. All right? So we're not like spending less to do worse. We're spending more to do worse. And what this is, and I don't want to get into the details of it, is it's hospitals, it's physicians, it's drugs, it's long-term care and nursing. Other personal care is probably other kinds of healthcare services. Other health spending is actually administration. What the purpose of my showing you this pie chart is everybody's responsible. All right? There's no single cost driver of the system. It's all that there's a lot of players, and when you think about that growth in healthcare spending, all these folks are making those dollars. As somebody once said, it's not just who's expending the money, but who's actually receiving the money as well. All right? And that's why changing the system is so difficult. And here's what it looks like for Missouri. Again, it's a little bit different, but largely the same. Your Medicare spending is actually much greater here in Missouri than it is nationally, at 24% rather than whatever. So why is this conundrum of access, quality, and cost so difficult to try to sort out? Well, it's because the fundamental premise of healthcare and the way that we pay for healthcare in this country is through fee-for-service. You go to the doctor and you get paid. You go to the hospital and the hospital gets paid. You go to the emergency room gets paid. So the more times you go, the more you get paid. And there's no incentive. There's no financial incentive. And because money talks and money drives the system, there's no financial incentives for you to stay out of the doctor's office or to stay out of the hospital. And once you're in the hospital, there's no financial incentive for the hospital to discharge you quickly and efficiently. In fact, they gain more revenue the longer you stay there. All right? So it's what we call a perverse incentive that actually acts against improved quality and reduced costs every single day. All right? That's the way that the system is set up. And so, again, the Institute of Medicine said 1/3 of what we spend on healthcare is unnecessary. All right? It's duplication, it's waste. So think about it just in a very, very common sense kind of way. I can't find that x-ray that I took because we're not coordinated, we're not talking to each other. So the simplest thing to do is do it again, right? So it's bad for you as a patient to get that additional radiation exposure. It's duplicative for the system, but actually the system rewards that. That says, if we can't find the x-ray, we'll just do it again. There's no harm, no foul. There's no incentive. There's nothing that says you can't do it again. All right? So even the common thing of being admitted to a hospital, again, before we have electronic health records, which I'll talk about, if I don't know what the records were that you had last week, let's just do that test again. All right? And over again. And that's the kind of duplication and waste that is in the system. So the real challenge, if we're going to fix this system, is that we've got to change, we've got to break this fee-for-service mindset. Because if we don't break this fee-for-service mindset, we will continue to have this incentive to just do more rather than doing better. All right? And so the other conundrum is who is responsible for making it better? All right? If we keep people out of the hospital where there's high costs, or what we often assume, let's keep people out of the emergency room because we all know that's the highest cost. If I do a good job as a primary care physician and keep my asthma patient out of the emergency room's actually kind of mad at me, all right? Because they're counting on that asthma patient to come in, all right? So am I getting paid somehow for doing a good job of keeping that asthma patient out of the emergency room actually isn't very happy. I'm not very happy because I'm doing more work as a primary care provider. So how does the system reward better quality and lower cost? All right, that's the problem. And then ultimately, as Dr. Troutman said, it's not going to be that downstream plucking babies out of the water. It's going way, way upstream, managing chronic conditions and diseases, and doing prevention. And again, who's going to pay for that? The healthcare system, hospitals are not going to pay for prevention. All right, so how do we work on social determinants in such a way that makes sense for the entire healthcare system? So Congress said, let's pass the Patient Protection and Affordable Care Act. And that's 900 pages of the law. And one of my claims to fame is I've read all 900 pages, not once, but twice. All right? But there's still things in it that I find and I'm go, really? That's in the law? I didn't know that. There's a lot in this law. All right? And the part that we have focused on, which is the health insurance coverage, is probably about 50 pages. All right? And the rest of it is what I'm going to focus on for the rest of this conversation. So it really is trying to do all three. Tackle the questions of access, quality, and cost. All right? And here in Missouri, I just want to say you're ahead of the game because you, again, with the support of the Missouri Foundation for Health, have done this analysis for what it means for Missouri. All right, so here are these two documents that talk about quality issues and talk about cost issues here in your state. So let's talk about access. So this is the part that everybody knows. We're going to make it easier for people to keep the insurance that they have. We're going to expand Medicaid. Oops, I forgot, somehow the 133 got lost there. It's up to 133% of poverty. And it's for everyone, so it's not this paternalistic a view that Medicaid and what used to be welfare was for pregnant mothers, but it really is for anybody who's low income. And then we're going to create these health insurance marketplaces that, at least the theory was that we're going to create 50 of these marketplaces. We've only created about 20 of them or 17 of them, but it also goes all the way up to 400% of poverty, so it's no longer for low income families, it's really for working families. All right? That's a pretty high level. And then what we're going to do is we're going to drive people into those marketplaces. So employers have to offer insurance, and then we've delayed that for a year. Individuals have to buy insurance, but then we're also going to try to work on affordability so that we're going to limit the cost of premiums, and we're going to limit the amount of profits that health plans can take. And so all these things went into effect. Some of them went into effect very early in 2011, and they're all in effect now in every single state. And so millions of people have been able to keep their insurance. Millions of people are no longer denied because of pre-existing conditions. And millions of youth are staying on their parents' policies. So this is helping address that $50 million figure of bringing that number down. Again, I said 400% of poverty is relatively high. So if you're a family of four, that's $94,000. All right? So it's still not a great income, but it at least allows working families to get some of the subsidies and some of the other help that they're going to be able to afford health insurance. So we all know that it didn't work out that all 50 states set up their own marketplaces. Missouri was one that did not. And so the federal government is running those marketplaces. Well, I expect this to shift over the next couple of years as politics in each state shifts and people realize that actually running your own marketplace is a good idea. The same thing with Medicaid expansion. Only about half the states took the option after the Supreme Court decision. Missouri is in the light blue. We're hopeful of maybe changing its mind. And I also expect that this will change as well over time. And then open enrollment is over for now. We all know about the not so great launch of the website. What I want to point out for Disparities is this is the first time that I know of that the federal government offered something in fully bilingual capability for Spanish-speaking folks. Again, the Spanish-speaking site had other problems that the English-speaking site didn't have, but at least there was a Spanish-speaking site, and at least the translations are accurate. All right? Generally speaking, it wasn't a Google translation that was awful. All right? And then in terms of language access, we know that there are other languages here in Missouri, like Bosnian and Vietnamese, that are more predominant. In terms of other languages, we have some nod to the fact that people who don't speak Spanish and English need access to this information. We have some static resources rather than interactive resources on healthcare.gov. We need to do better on that, but at least there was some attempt to move on this. So the good news is 8 million folks and counting. It will probably be about 8.5 by the time we're done. Did sign up for insurance through the marketplaces, both the ones that the federal government ran as well as the ones that the state government ran. I can proudly say California was responsible for 3 out of that 8 million. But also California has more people and more uninsured, so I'm not sure that that's necessarily a good thing. What this says is we're still a long way from covering all 50 million uninsured. So yes, we should celebrate this dramatic change, but we have a long way to go, all right? And we need a lot more people enrolled in Medicaid than those 3 million. For LGBT folks, this was also a first time that health insurance really was accessible and affordable to LGBT folks for a whole lot of reasons that I can elaborate on in questions and answers. But the really important thing here is, as an immigrant rights advocate, the one population that will be left out, and the boss of the current CEO of the organization I used to work for says that starting January 1st, 2014, the single determinant of whether or not you're insured or uninsured is your immigration status. So think about that. The single most important determinant of whether you're insured or uninsured will be your immigration status, all right? Because undocumented are left out, and even legal immigrants who are here for the first 5 years of their permanent legal stay in the United States are also left out of Medicaid expansions as well. So this is a really important social justice and equity issue. To fix this, we don't think there's going to be comprehensive immigration reform, but it's really important to tie the issues of immigration and health together. So what about quality? What the Affordable Care Act does, and there's another couple hundred pages of the Affordable Care Act, of that 900 pages, is for the first time, rather than just saying we're going to keep reporting every year that quality isn't getting any better, we're actually going to set some goals. We're actually going to say, let's do better. And let's do better in a very quantifiable way. All of you who do program planning, you can't make progress, you can't evaluate and measure your progress if you don't have a goal, right? You don't have an objective. So for the first time, we're setting actual numerical objectives and goals, which is an amazing thing, all right? And I'll talk a little bit about how that's playing out. The second most important thing about quality is actually not part of the Affordable Care Act. It was part of the economic stimulus bill, the High-Tech Act, which created billions of dollars, $30 billion, as part of that stimulus package to buy electronic health records, to support electronic health records. That was the economic stimulus part. Lots of electronic health record vendors are very, very happy right now because they got a lot of money out of that stimulus. But the important thing is that it pushed doctors and hospitals to move into the electronic age, finally. All right, and I'll talk about that, of why that's important for equity in just a minute. And then we're going to do things like this notion of a medical home and improving those transitions and coordination of care so that people aren't back in the hospital and aren't harmed by their stays. There's lots in the Affordable Care Act about workforce development, about moving from physician-centric models to more team-based models. And then also this notion, which is I think also really important, moving a research paradigm from a researcher-led investigation to actually a patient-led investigation. What's important to the patient? What's important from the patient perspective? So let me talk about these. Here's the strategy plan. And one of the things that it did was let's do patient safety, first and foremost. Let's stop that 1/3 harm in hospitals. And so 3,700 hospitals have signed up, and we are seeing those patient safety specific numerical goals actually get achieved because the federal government has set those goals, all right? Embedded in all this is equity. So the Office of Minority Health also issued these health equity plans that actually match and are parallel to the quality plans. And so we've synced up equity along with quality. And then let me talk about electronic health records. What it's going to do is it collects that information, it shares it not only with the patient but with other providers. So that issue of I can't find the x-ray, I can't find the blood lab result is not going to be as much of a problem, hopefully. It supports clinical decision making, so it actually nudges doctors that say, this is actually what the guidelines say, maybe you should think about talking to your patient about that, prescribing this medication. It supports, and this is the equity part, it actually opens up the provider-patient interaction, because by giving access to the information, and so back to the breast cancer example, if patients are more informed, if they know what their records are, if they know why are you continue to prescribe this medication when you told me that I didn't need it anymore, it's going to correct those kinds of errors. All right? So the more empowered and engaged we are, and I always say it's not just patients, but it's patients, their families, and their caregivers, however that's defined, and the electronic health record will allow you to do that. So in the care of my father and stepmother, they weren't ever going to use electronic communications, but I was emailing back and forth with the providers all the time as their son, all right, and able to then help manage their care because of that. And then it will actually monitor the quality improvement. The most significant thing for disparities is it will give us the data. So those of us who have worked on these issues for a long time, we were constantly fighting this battle of should you collect race, ethnicity, and language data? How should you collect race, ethnicity, and language data? Why should you collect race, ethnicity, and language data? And then most importantly, what do you do with it after you actually have it, all right? So debate is over. Every single hospital is going to collect race, ethnicity, and language. And in the new requirements, they're now considering collecting disability status data. They're going to start to think about collecting sexual orientation and gender identity. So again, the debates will be over because if it's included in the electronic health record, it will be there. And then the challenge will be to actually use it. So I think this is the most significant development for health equity, because we will have the actual data in real time that we can pull and say, how are we doing with our patients with diabetes? And specifically, how are we doing with our Latino patients with diabetes? Or how are we dealing with our Latino patients who speak Spanish with diabetes? And we'll see those disparities, and that will be the rationale for the interventions. All right? So again, it won't be theoretical. It won't be waiting for these national reports. It will be in your hospital, in your physician practice. You will see those disparities in front of you, and you'll be able to act on them. So I think because of that, there's huge potential. The other thing that is a hidden secret is that African Americans and Latinos are using their smartphones to access the internet more than whites and Asians. All right? So if we're not texting with African Americans and Latinos, we're not taking advantage of technology that is literally in their hands. And so they will no longer be the hard to reach populations. It's that we won't have figured out how to reach them effectively and in a very, very cost-effective manner, because text messages are going to cost you nothing. All right? So how do we use this technology? How do we engage communities in these kinds of solutions? It's going to be an amazing way in which we can think about disparities in different ways. And here in Missouri, you've got some infrastructure in place to help providers navigate implementation of electronic health records, and then begin to share that information. This model of the medical home is really, really important. Back to the play, really developing that relationship of trust between a provider and a patient and the patient's family and caregivers. And again, in the same way, medical homes can really advance health equity, because it is about learning about your patient and the conditions in which your patient lives. And I will do a slight editorial aside here. How many of you have heard of the book, The Spirit Catches You and You'll Fall Down? Often used as a classic textbook in medical school and health professions training. I'm actually very critical of the book, because one of the things that comes out in the book is that all the providers who were treating the Southeast Asian girl with epilepsy had never visited the home, had never actually been in a home of a Southeast Asian. All right? So they didn't understand the culture. So simply having that kind of familiarity and trust and relationship with patients and the community that you're serving, I think is what medical homes are going to try to be. Now, whether or not we get there is going to be part of the challenge. What will also help us with medical homes is that they will have a lot of equity components, and this is from the 2011 version of the National Committee for Quality Assurance Recognition Program. These requirements carry over into the 2014 version that they just released, and it's that explicit. It says you've got to provide translation, you've got to provide interpretation, you've got to get feedback from vulnerable populations, you have to reduce health disparities, all right? Otherwise, you're not a medical home. Otherwise, you won't get recognized. All right, so here's another tool to drive not only equality and cost reduction, but also equity. And then lots of work on transition to care. I see one dot in Kansas City. So one hospital and community is working on that here in your state to really think about those transitions so that people don't come back. Patient-centered outcomes, millions of dollars going to this research, and one of their 5 priorities is addressing and reducing disparities. So again, able in that new research paradigm to also address disparities. And then finally, cost. So those readmissions that came back, 1 out of 5, we're going to start saying, you don't get paid for the second readmission, all right? If it was avoidable, if it was something that could have been foreseen. We're going to shift, we've already talked about this a little bit, from the fee-for-service, volume-based payment, to a value-based system, all right? And we're going to put new names on it. I don't think accountable care, my personal opinion, will necessarily last as a term, but the notion of a value-based system and organizations' integrated systems will last. You have to do that in the future. And then we've got this other really interesting thing about bundled payments, which is a hip replacement should be a hip replacement. And there should be a range of complications, and you should be able to do it for specific costs. There shouldn't be this wide variation in hip replacements, all right? So those kinds of procedures that are done over and over again, we should be able to bring down the costs, and that's going to mean less provider autonomy in choosing my idiosyncratic way of doing it that's actually going to increase costs, but that's really what we want to do. So readmissions are actually coming down. Accountable care organizations are being created all across the country, including, again, Kansas City and Missouri. There is already some thinking about what about disparities populations in accountable care. And my view on this is taken from the Center for Healthcare Strategies, which says if you're looking in accountable care of sharing savings between hospitals and physicians and trying to reduce costs and increase quality, what population has the highest costs and probably the lowest quality? Disparities populations. So sooner or later, you will get to the disparities populations. You may decide to go for easier wins first and work with other populations, but ultimately, you're going to have to address disparities, all right? Because those are your highest costs and your lowest quality, all right? So accountable care, if it's smart, is going to be thinking about those populations early and rather than later. Lots of experiments on bundled payments. And then what I like is this little bit of humility from the federal government, which is part of the great thing about the Affordable Care Act, which is the federal government said, Centers for Medicaid and Medicare and Medicaid Services, we don't know what all the answers are. So here's an open competition. It's innovation. Come on down with your ideas. And so 107 organizations got a total of $1 billion. And they have said to the federal government, you give us $1, we'll save you $1.90. I guarantee you all 107 of those organizations will not succeed, all right? But it's okay. They don't have to return the money. We're going to learn out of that $1 billion investment. And that kind of innovation and that kind of opportunity, for those of you who are entrepreneurial, exists. Health plans are willing to do this. Employers are willing to do this. And there's money. There's actually a second round that we're waiting to be announced for this innovation round. So Don Berwick, who was temporarily at the Centers for Medicare and Medicaid Services, actually reimagined the access, quality, and cost triangle in a different way. And so I want to end with this. What he said was, it's not about insurance or no insurance, because people get care in the system or out of the system. They will eventually get care, even if it's in the emergency room. So let's get the best experiences of care both from the patient perspective as well as from the system's perspective in terms of efficiency and quality. And then when we talk about quality, we can talk about all kinds of different quality measures. How are you doing with your diabetes measures? How are you doing with your asthma measures? But what he really does is back to what Dr. Troutman talked about this morning, which is it's about the health of the population. Are we a healthier people, all right, at the population level, not just at the individual level, but in an aggregated way. So let's call it what it is. It isn't about us incrementally doing better on these measures, moving from 70% to 80% and then saying, hey, isn't that great? We're at 80%. But it's, are we actually healthier as a nation? And we know we have a long, long way to go. And then finally, in terms of cost, rather than saying it's about saving a few dollars here and a few dollars there, it's the entire system is too costly and not giving us the benefit that we need. So we have to reduce costs. That's bad news for all of us who are in healthcare because it means that people will lose their jobs, all right? So that's the downside of this, is that as those costs shrink, as that part of the economy shrink, people will have to, the existing people that are being paid those dollars may not be able to survive. So the entrepreneurial opportunity is, especially from a community-based point of view and disparities and equity point of view, is what are the new jobs that we can create? What are the new opportunities? It may be different people, but it's another way of thinking about it. So I end with the way that I began, which is I now talk about the work that I try to do as both focusing on patient-centeredness and focusing on equity. And I didn't come up with those terms. It actually comes from the Institute of Medicine, from their Crossing the Quality Chasm report, which talks about equity and patient-centeredness as 6 of the pillars, important ingredients of healthcare quality. So lots more in that 900-page bill about quality and equity, lots more about patient-centeredness, and I've prepared a resource sheet that has all these citations and all these reports that we'll share with you afterwards, so you don't have to write all this down. So let me spend the last 5 minutes talking about where I see all this going in the future. So in the future, with the Affordable Care Act, I think we obviously have to keep moving to chip away at that 50 million people uninsured, and that's going to mean coverage for the uninsured, Medicaid expansions, language access, and fixing those immigrant exclusions. And ultimately, to universal access, so that it really is about people getting services and not having even that insurance layer between them. It's really important in this transition period to be thinking about the safety net. Those of you who work in community health centers, who work in public hospitals, those small and even solo practices, but all these folks need to be prepared for less funding, all right? Because the dedicated funding that they got, because they were serving the uninsured, is going to dry up sooner or later. So they've got to be thinking about value-based payment, thinking about accountable care organizations, thinking about new ways of workforce configurations. And then all these other kinds of specialty services also, I think, are ultimately threatened. Because again, people theoretically are insured and will be getting these kinds of services. All right, so be thinking about if you're one of these kinds of service providers who are providing what I call specialized services with dedicated funding, you're going to have to find partners, especially with primary care, to say, how can you be of service? And so the one example that I give is folks who work on HIV are really, really good at case management, at medication management and adherence, making sure that people take their medication, are really good about identifying mental health issues that may affect that person's health and well-being. That sounds like really good diabetes management. Case management, medication management, identifying mental health issues, other life issues. So could that HIV agency start providing care and learning about diabetes management and providing that as a service in their particular community? Primary care has to be comprehensive, and that's the other opportunity to include behavioral health, substance abuse, mental health, oral health, and prevention. This notion of thinking about healthcare workers in a different way so that it's not just physician-centric, but using nurses, medical assistants, physician assistants, community health workers, using everybody that's already in the system and scaling up their skills and their licensing and really this notion of working at the top of their license and training. Coordinating that kind of care and looking for partners. The good thing about this period of innovation and experimentation is that in the old days, you had to merge legally in order to work together. And now with things like accountable care, you don't actually have to legally merge. You can create clinical integration in a way that makes sense, clinical and financial integration without legal integration. And then leveraging health information technology, especially mobile health and text messaging and smartphones. If you're in the safety net, if you're in the community working with disparities populations, you also need to be thinking about what's, again, that high volume, high opportunity to reduce costs and increase quality. It's going to be harder with your populations, but you can do it. And so how can you document that, and how can you say that that's a value proposition to partners? And then obviously, in many ways, starting with this, there's a lot more patient-centeredness in healthcare, informed and shared decision-making. Patient satisfaction measures are going to count more. And then finally, we have to go beyond healthcare and think about public and community health, partners outside of healthcare, as Dr. Troutman talked about, health in all policies. And that's it. And I left 15 minutes for questions and answers.
Yes, we do have time for questions and answers, so if anyone has them.
Thank you. Really informative. You spoke about how safety net providers need to be prepared for decreased funding. How does Medicaid expansion play into potential new sources of funding from safety net providers?
So Medicaid providers, historical Medicaid providers, whether they're primary physicians or community health centers, relied a lot on Medicaid. But almost every Medicaid program is moving towards medical homes. Some Medicaid programs are moving towards accountable care. So Medicaid is also moving away from fee-for-service into these other models. And so if I'm a community health center that's used to saying, that's great, if I can expand the number of patients that get Medicaid, I get a higher rate, I'm set. I don't have to do anything. That's not going to be true anymore, because the way those Medicaid dollars come into that community health center are going to now be dependent on these other ways. My prediction also is that at some point, the medical home model has become so pervasive that you won't be a Medicaid provider unless you're a medical home at some point. Yes?
You mentioned in one of the later slides that one of the areas that would be that there be reduced funding is women's health. Can you explain that?
So any population-specific condition or disease-specific funding, so whether it's Ryan White funding, whether it's substance abuse funding, whether it's reproductive health services, again, the theory is going to be, the argument will be in Congress. Everybody's insured. Everybody has access to health insurance. Why do we need women's services here? Why do we need reproductive health services here? Why do we need substance abuse services here? They should be getting those services from their primary care provider or their medical home. So again, my advice is if you are a women's health service provider, think about how you can partner with primary care, how you can partner with accountable care and integrated care, so you can say, I'm bringing these patients with me, and we're going to do a lot more for them. So rather than, I'm going to pull out women's health services here, you're going to become much more comprehensive. And it may be in partnership, but it's going to require Planned Parenthoods and other women's specific services to also be thinking in that way. Yes?
My question is, you mentioned in passing population and community health strategies, and I'd like to hear you talk a little more about that, and specifically about what you see as potential future funding mechanisms for that. Always get the short end.
Great question. So Dr. Troutman this morning talked about how big sort of taking a population community health social determinants view is. So it's not going to be any single funding source or any single stakeholder that's going to do that. I think one of the things that a lot of hospitals and health systems are doing, for example, are using their community needs assessments processes to say, rather than holding a health fair, which is nice, does some education, let's actually take a population health approach to how we respond to a community needs assessment. If we think, and Kaiser has pioneered this in a lot of ways as a system, if we think part of the issue really is access to fresh fruits and vegetables, access to better physical activity, let's invest in that as part of our community benefit at a population level, rather than just doing a health fair once a month. All right, so that's a small amount of funding. I think the collaboration between public health departments and health care, which again historically has been siloed. We teach medicine and then we teach public health. And we have some joint programs. But again, that's another opportunity that public health can bring some dollars. But it's disease specific, it's condition specific, it's not coordinated with health care. So I think then again in these new configurations like accountable care, that a lot of folks are going to have more of this population community view and be more willing to invest some dollars into that. It's not a perfect solution, but there's some room there. Yes?
My question is regarding meaningful use and the use of health information technology. I am a dental provider, and I think that those are really great things for the medical community, but they haven't integrated them to oral health. So do you see that changing in the future? Absolutely.
So dental providers actually have electronic health records. They just have a different set of electronic health records that don't talk to the medical electronic health records. So in California, actually, I'm working a little bit with the University of Pacific, actually using both telehealth as well as using electronic health information technology to bring oral health services into schools, into other situations, but really propelled by the technology platforms. And the exciting thing about that is they're now in conversation with the state innovation model application to say, can we put an oral health component into the quality measures that we're going to be measuring for the state? And that's also going to help drive that. So there's some conversation. I think, again, editorial aside, we missed an opportunity to include oral health as an essential health benefit, especially for adults. It is there for children. And so that's a missed opportunity, and that's another place that we can do some advocacy and policy work as well. Other questions?
All right, if there are no more questions, then we'll get to our break. I'd like to remind folks that the panels start at 2:15. Oh, let's all thank Mr. Bao. I'm sorry.